wanted to ask you about like the difficulties that you had from access all the way down. If we can walk through that. The first one is obviously spasm. So you're advancing the sheath, you have spasm. What do you do?
Yeah, so great question. In terms of spasm, the key is upfront, I believe, really good sedation. So as soon as I walk in the room, we get a blood pressure, the patient's prepped or getting prepped. I already, if they're able, I give them generous sedation. And then I have the artery. I actually give much more local anesthetic than I would in the coronary cases. I give more generous, even a little bit more proximal in the arm. I find, and I don't know if that's more just for my sake, but I try to numb up that whole area. I'm really advancing the first short sheath and getting a feel for getting into the space, into the descending, to see how this patient's going to act. If I already have some spasm or I'm a little concerned, I then pretty much stop. I give more sedation, and then I reintroduce cocktails. Yeah, so I'm usually giving Cardine in our lab, 200 to 400 milligrams. I give nitroglycerin, 200 to 400, as well as heparin. Sometimes we also will have verapamil. So depending on kind of the hemodynamics, what's going on, I'm very generous with giving repeat doses of that within the radial artery. And every time there's an exchange or there's a time, I'm always flushing the sheath so that there's no, I don't think, any thrombus or anything else developing within that. I do hydrate these patients so they're getting fluids as well throughout this. But I'm always assessing comfortability, because once I know they're waking up and they're starting to feel things more, that's again where things can go sour. So I'm really having my nursing and my staff just understanding that. And if there is like, oh, the patient's really getting a little awake and feeling things, I give another round of sedation. So I think those are all really key, because the major thing from my perspective is once I get and I target a zone where my sheath is going to be for the intervention, I want to lock it into place as the base of operations, and I don't move it. I don't advance it. I don't pull it back. That's where it's going to be, and I pretty much lock it into place.
Sam, tell us about your experience, especially also the catheters that you use going down the descending in type 2 arches.
Yeah, I think Shay mentioned it. I'm a big fan of GR4, 5 French 125, dexterity. It has a nice curve to it. Many of the operators also use an IM, multi-hole IM, 5 French 125. Some like vert. I'm not a big fan of the vert. Just hard to get up and over, or those kind of type 2, type 3. But it's nice for taking picture, because when you get to the iliac, it's not against the wall. But I think the secret sauce is what Shay mentioned before. It's the pigtail. I mean, 5 French pigtail does magic, and because the way you flip it, and you can use I don't use the glide wire and like as my first wire. I just use a J wire, and it works commonly more than 85% of the time. But for those really complex cases, soft glide works really nicely. And sometimes the radial, like any technology, you should not do your first case as the most complicated case. Then you're not going to be a believer. You can't do your first lymph flow in a case that patient had, I don't know, multiple intervention and things like that. You can't do your first detour and someone had a multiple bypasses. You can't do your first biobservable scaffold and someone who had multiple intervention. You just have to select your patients, the first few cases, just kind of get the sense of it. The other thing that I think important, I think Shay mentioned really briefly, but I want to ask both of you of the importance of teaching and training staff in any new technology. I want to ask Shay specifically about radial to peripheral, and Hady, you've been pioneering so many things that's new. How do you get your staff to have a buy-in and believing in it? So start with Shay, and then I'll maybe bounce to Hady afterward.
Yeah, great question, Sam. For us, what was really important is educating the staff and having that very open dialogue. We do have education every Tuesday morning with the staff, so they various topics, and so what we did for one of those discussion points is what is the interest in doing radial to peripheral and why we do this, kind of talking about the same things we're talking about today, right? So from a patient perspective, from a workflow, from safety, all of those things, but also understanding that, it's something that we do every day in the coronary space. And as interventional cardiologists, we're very experienced at that. So it's an extension of that, but we want to utilize some of those benefits to fix and help patients in the periphery. We went over the ergonomics of the room and how we're going to set them up. We realized that, just like anything else, what you're used to, you're best at. And so that's probably why I do a lot more right radial if possible, because it's just in our workflow. We have tried doing left radial and really flipping the room. It is feasible. It does change how kind of you're standing and the wire manipulation. I wish I could say I'm as good in that way, but it's going to take some more work to really do that in the reverse order. What we do in a lot of cases that we do left radial anyway is we're able to pull the arm over and we do left radial access. Well, the staff, I think, has really grown to appreciate that, what the benefits are. And that I think the other thing, Sam, like I mentioned before, is I'm really upfront about knowing what we're getting into before the case starts. So I have a game plan, and before the case, we go over everything. I say, what we've known is that this is an SFA blockage. We're looking to do such and such modification, and this is kind of the plan in the stepwise approach. Obviously, that's not always 100% what's going to happen, but I really have an algorithm before I step foot in these cases because I find that workflow is incredibly important. And I will say I try to be very quick with radial to peripheral cases because the longer you stay in there, the risk just increases, the pain increases, the spasm increases. I don't want to sit there for 4 hours trying to mitigate, a case from radial to peripheral. I just don't think it's a good idea from my perspective and the patient's perspective. So I will take that extra step in preoperative planning. Like I said, sometimes more imaging or a CTA just to understand what we're getting into. And then we will have all our tools laid out. Earlier in my experience, I did have a few cases where we weren't able to treat the way I wanted to treat, either due to length, lack of tools. It just the reach wasn't there. I didn't have the support. I never want to be in that situation again because then you really have to pivot, start all over. And that's a real tough mindset to be in the middle of a tough case. So I take that time up front. And I think the staff really appreciates knowing the workflow, being involved and engaged. And I think that's helped our lab a lot.
Shay, it's scary how similar our practices are. It's just exactly the same. What you said, that doesn't take that long. It's not a 15-minute meeting. This is a 2-minute huddle right before the case. And the empowerment, asking the staff, Sam, you were asking me how we get them involved. Just ask them their opinion. What do you think? Is that going to be easier? Is this going to be faster, more efficient? Of course, sometimes faster is not the answer, especially if we have problems with groins and patients who want to sit up quickly. So we take that into account. What do you think about this patient who's going to complain about back pain and be very difficult, etc.? So empowerment of the staff and the huddle before the case and asking for other ideas. Sometimes I honestly was impressed that my staff had other suggestions like, you know what? That's even a better approach. Let's do that. And they take it and run with it. It's very, very helpful. That is definitely somewhere. And the other thing is obviously having them be part of the decision-making, especially in conferences and all that, like you mentioned. Yeah, that was kind of my experience. And if things don't work, you can always adjust.
Correct.
Yeah, we have a very similar approach. It'll be surprising how, especially I think for a physician who newly graduate, one thing that we have plenty of is egos. I think when you come out, we're doing 500-600 PCI, God knows how many peripheral structural, you're at the top of the world, but you have a tech or a nurse who's been in practice for 25 years, who's done 5 times, 10 times, maybe 100 times more than you've done. And I think their opinion absolutely matter.